Taking ahead from what Dr. Biswas has said, I will be stressing on the importance of blinking in order to prevent ocular surface disease. So this is my financial interest. So overall prevalence of dry eye disease ranges widely, approximately 50% in different population-based studies. If we look at the prevalence of dry eye in India, amongst the mobile, computer and tablet users is almost 89%, and amongst diabetes mellitus patients is almost 76%. So these are the types of dry eye we all know: aqueous deficient dry eye disease, evaporative dry eye disease, and mixed dry eye disease. So 4 out of 5 dry eye patients have some form of evaporative or lipid deficient dry eye. In a large demographical study comprising of almost 14.5 lakh patients in India, 21,290 patients had symptoms and signs of dry eye disease, of which it was seen that a mixed dry eye disease and evaporative dry eye disease comprised almost 4/5 of them. So these are some of the risk factors for evaporative dry eye. Poor blink rate and incomplete blink can lead to increase in tear evaporation. The blink is essential to preserving tear film homeostasis. During a complete blink, the mebum is released from the oil glands to the lid margin for dispersion onto the tear film. When the upper lid does not meet and overlap the lower lid, less force is exerted on the glands, resulting in mebum expression into the lower lipid reservoir. Uneven distribution of the lipid layer across the ocular surface, and instability of the tear film, and a lower tear breakup time, and increased tear film evaporation. So if we look at the digital eye strain and evaporative dry eye disease, decreased blink frequency and increased incomplete blinks lead to 4 times evaporation of the tear film, ultimately leading to hyperosmolarity, inflammation, ocular surface damage, and tear film instability. And this goes on and on and on. So MGD is the most common cause of evaporative dry eye disease. Meibomian glands in those patients drop out, they block or they get inflamed. Stasis of the mebum inside the gland causes proliferation of the bacteria and mites, increased lipid degrading lipases and esterases, increased viscosity and melting temperature of the mebum, decreased secretion of the mebum on the surface of the tear film, and completing a self-sustaining MGD cycle. So if you look at the diabetes and evaporative dry eye disease, decreased corneal sensitivity, which reduces the blink rate, leads to destabilization of the lipid layer of the tear film and results in increased excess evaporation. Also, higher meibomian gland scores, lower mebum expressibility, and lid margin abnormalities contribute to the dry eye factor. 4 out of 5 patients, as I already told, have evaporative dry eye component. Hence, optimal identification and management of evaporative dry eye is essential. World Council of Optometry recently published a dry eye wheel to simplify screening and management of dry eye. I'll be focusing on this part of the bronze ring, which consists of validated questionnaires, detection of comfort time after blink test, blink rate and completeness of blink. Alcon has developed a device, a very simple device to count how many seconds the patient is comfortable after one blink. So if it is less than 10 seconds, repeated 3 times, is indicative of dry eye disease. And while examining the patient, you should look at the completeness of blink when the patient is sitting on the slit lamp, and to find out whether the patient is blinking completely or not. If not, then he has to be counseled about proper blinking and its good effects. Coming to the management, the lipid layer normally ensures decreased aqueous evaporation by 90 to 95% and decrease in the surface tension of the tear film phase by 25%. Patients without a visible lipid layer have found a 4-fold higher rate of tear film evaporation versus with a non-continuous lipid layer. Emollient drops are thus developed. So in lipid-based artificial tears, useful in dry eye disease of low blink rate and incomplete blinking, a step closer to natural tears, longer lasting lubricating effect, minimal interference with vision, more effective than aqueous tears, effective in all types of dry eye. Whereas traditional aqueous artificial tears, temporary symptomatic relief, they do not target the underlying pathophysiology. High viscosity increases efficacy but decreases tear clearance and blurs vision. So Systane Complete works on all layers of the tear film. The HP Goer forms a hydrophilic meshwork cross-linking with the muco-aqueous layer, creating a protective elastic matrix. Nanosized lipid droplets migrate to replenish the top lipid layer of the tear film, repairing the gaps and providing complete coverage for the lipid layer. Coming from one of the studies by Craig et al., it was to compare the efficacy of Systane Complete and Systane Ultra for management of dry eye disease to determine the therapeutic profile for clinically significant improvements of signs and symptoms, including the magnitude, to assess whether the clinical outcomes are influenced by baseline dry eye disease subtype or severity. There was 134 patients in the study, out of which eligible patients were 99. Systane Complete was given in 50 and Systane Ultra in 49. There was equivocal response as far as dry eye questionnaire was concerned on OSDI, DEQ5 and Sunday. The tear film quality was improved in both of the eye drops from day 120 onwards. But if we look at the tear film lipid layer, Systane Complete and Systane Ultra were similar up to 90 days. From 90 day onwards, the Systane Complete, it showed a marked improvement of the lipid layer thickness in the Systane Complete group. To conclude, evaporative dry eye can occur as a result of anything affecting the eyelid. 4 out of 5 cases of dry eye are evaporative dry eyes. Lipid-based artificial tears are effective in evaporative dry eye as they mimic natural tears and replenish lipids. Systane Complete works on the lipid layer and muco-aqueous layer of the tear film and offers solution to all types of dry eye patients. Thank you very much.
Thank you, Dr. Mohanta, and thank you for all the speakers in this. I think it was an excellent session on cornea challenges, and we'll turn it over to the next speaker.